Hi, everyone. This is Dr. Rodiales from the CNY Fertility Atlanta office. I know I've been gone for a few months. I had to regroup and take some time, some personal stuff. You know how life goes. Some of you come back after having a few adventures of your own and say, I'm ready to retake the fertility project in this case. In my case was I'm ready to retake my life. Anyway, I always like to start our chats with some interesting cases or subjects that have arisen in the last few weeks. And I want to bring up two cases. One, a 49-year-old that had she's doing donor eggs. She last period was 2014, and getting ready for her first transfer, she would not respond to estrogen. That's a story that some of you have seen before. So super high dose of estrogen. She was doing three estradiols orally, vaginally, patch, no budge. Her lining kept fluctuating between 4 and 5. And for those of you that have been through this journey, you know that that magic 7 minimum is what we're seeking, trilaminar 7 millimeter. She didn't get there. And she was very frustrated. And after a very, very long attempt at getting that lining up, it was decided to regroup and cancel. So the big question is what's next? And so the standard of care, especially for that scenario, would be to use estrogen progesterone because using ovulation medication and doing a modified natural cycle with letrozole would not be a choice, right? So I discussed with her a few things. One, just mechanical. Well, first, I put her on birth control pills to try to get that lining, that uterus to start responding to hormones. We're going to do uterine priming. Some of you have heard in some of my old videos about uterine priming. I put her on glandular therapy. Uterus and ovary glandulars and some other supplements to assist the better functioning of the female organs. So one, birth control pills to get her to start cycling. Two, certain supplements to help functioning and providing the exact nutrients for those organs to work better. We're going to do serial PRP. I even suggested doing an endo scratch, mechanically stimulating that lining. So I think of the endo scratch as stalling the soil, and then the PRP is like the fertilizer, right? So you told the soil, pull the fertilizer. It seems to work better. So we're going to do that every month for the next 3 months. Massage, fertility massage, get that blood flowing to that area, and acupuncture. So with her, we're going to try that and see how it works for her for trying to get that lining so she can do an FET in about 3 months. Now, during the attempt at the FET transfer, we're going to add mupogen. Mupogen helps build up the lining as well as Viagra. It was used Viagra, but I want to include that as part of her program when we try it again. So that was an interesting case that I wanted to share with you. And the other case, and this was really very, very unusual scenario. So I have a patient with a coagulation disorder. She has one NK factor, NK cell elevated, and antiphospholipid syndrome. And so she was doing a dual stim, and she was on anticoagulation. She was on Lovenox and aspirin, actually, which that's what she was on. So then she did her first retrieval, got five eggs, 3 embryos, and went straight into a second stim. It was going very, very well for her in that second stim. She had a total of about 12 follicles, and then she started bleeding vaginally profusely. And the question was, do we stop? What do we do? Because she was doing so good. So what we ended up doing is using vaginal progesterone to try to stop the bleeding, stopping the anticoagulation, and that did the trick. We ended up doing her retrieval on Monday, got 7 eggs and 3 embryos. We're super, super excited. But that was a very unusual scenario, kind of in a crossroad, what to do, safety first, right? So luckily with some vaginal progesterone, we were able to stop the bleeding and discontinuing the anticoagulation she was on. The bleeding stopped within 12 hours and we were able to continue. So that was very, very, very challenging. So so those are the two cases that I wanted to bring up tonight. Let's see, do you guys have any questions for me? Hi for everybody that is joining us. What is a duostim? So a duostim is when you go through a stimulation cycle. You start your IVF process, you go on the beginning of the menstrual cycle, or sometimes you don't need one depending on what's happening. You go through that, you go through a retrieval. All right. And then a few days later, usually 3 to 5 days later, you jump into another stimulation. So you do back-to-back retrievals. That's what a dual stim is. And even though that is awesome for some women to be able to harvest eggs and bank embryos, as you can imagine, it can confuse the body a little bit and it gets the uterus completely out of sync. So during a dual stim, you cannot do a fresh transfer. In the case of my patient, there was breakthrough bleeding that was probably worsened by the fact she had fibroids. So that uterus was already having issues with contractions, because fibroids will interfere with the contractility, normal functioning of those muscles of the uterus. And she was on anticoagulation. So one, probably abnormal shedding of the uterine lining because of the hormones up and down, all right? And contractility issues and the coagulation issue because we were trying to prevent possible clotting due to her coagulation disorder. And I have a question here. How many days on an average would you stim for duostim? It's exactly the same. So the average for stimulation is 9-10 days. We really want to see it go into 9 to 11 days because it's associated with better quality eggs. So you go through a stim like you would normally do, trigger, retrieve, 3 days later, start again. And it's another, 10, 11 days of stimulation in most cases. What do you think about L-arginine supplement before an FET to help with uterine lining? I like it. I've seen mixed results with it, but like the case of the lining that I was describing earlier, anything that helps, add the L-arginine, maybe that will add a little bit, and it all adds up. So in the case of the lining challenge, that's where I was discussing with her, okay, let's do the PRP, the endoscratch, let's get your body to cycle. Let's get you on different supplements, including glandular therapy. And then during the actual FET, doing acupuncture before and during the FET, Viagra, and all those things that will increase heat and blood flow to that area. Okay. Okay. Hi, Doc. How many days of stim or dual stim? I'm in the process. It is a 13 of stim, and nurse still say that we need a bit more. That can happen, especially on the second stimulation. Sometimes we need a few extra days. Usually the first stim will be more like the usual 9 to 11 days, give or take. And then the second one, sometimes, not always, will need a few extra days. So that's where we monitor you because everybody's different. Okay. I just had a retrieval, 3 follicles, and no eggs. The last cycle I did in April was the same, no eggs. Yes. So what happens? It's going to depend on your ovarian reserve. So there's multiple factors that will determine whether you have a successful retrieval. Obviously, the biggest, largest will be your ovarian reserve and your age. And sometimes I had a discussion yesterday with a patient who was 40 with an AMH of 2 and did not have the results she was expecting. And this was IVF number 3. She had IVF at a different clinic, only 2 embryos that didn't grow to blast. She wanted them PG tested. That didn't work out. Came to CNY. This was her second IVF. First round of IVF, 2 embryos. Second round of IVF, 3 embryos, which is a little better, but day 3 embryos and not quite working the way she wanted to. So her body was really behaving like a 40-year-old. And the statistics say that once you hit 40 and beyond, the chances of being successful with your own eggs is like 10%. All right. So, and then sometimes people do more like the number, because I had another patient, 31-year-old with AMH of 0.3. And, again, scenario where she was just getting just a few embryos out of her retrievals. Having a follicle does not guarantee having a good egg. All eggs come out of a follicle, all right? So you can, in theory, think that at one point that follicle was developing to give an egg. However, depending on the functionality of the ovaries, the egg could die inside, like a missed abortion, okay, where you have an empty sac, and that is what happens. It starts the process of creating an egg, and either the egg is defective or it dies before full development. So when we aspirate the liquid in the follicle, it's an empty follicle. Okay. Should I stop trying with my own eggs, and how do I prepare for transfer? Donor eggs is a very controversial, very deep process. And I understand, as a woman, it's a hard bridge to cross. However, all the ladies that have had that decision made and cross over to using donor eggs, they all say that they wish they had done it sooner, because it is your baby. Okay, you're going to carry that child. You're going to get nauseous like every other mom. You're going to be uncomfortable and miserable pregnant like every other mom. You're going to deliver that child, breastfeed if that's in your plans. And when you're holding that baby in your arms, the last thing in your mind is, where did the egg come from? Most donations are anonymous, so even better. Okay. You have to be ready to make that decision. I can understand that. You have to get to that place in your heart where you're ready to make that decision. And it's very individual. It could be after 1 or 2 IVFs and you're ready. Or I have patients that it takes them a little longer, sometimes years of trying on their own, or on their own IUI, multiple IVFs, priming, until they get to that place where they're ready. We had a beautiful lady graduate from the program last week after a 24-year journey. She had been married 24 years. The first few years, she was not ready to start her family, but when she was, she ended up having 2 ectopics, losing her tubes in her mid-30s, then starting the IVF journey, and realizing in her late 30s that she was starting to go, not through menopause, but very low ovarian reserve. She ended up having, she ended up testing her embryos at one point that were normal, and then they would not attach even with normal embryos. She probably had done with her own eggs probably about 6, 7 IVFs. And then she finally made a decision at 43 that she was done with it. I mean, it's very personal. And she did donor eggs, and last week she was 9 weeks pregnant with a beautiful baby. And we were saying goodbye. It was very, very emotional. And she was like, oh my God, I can't believe it. I made it. And I really don't care anymore where the egg came from. Okay. Okay, let's see. Do I recommend Ovasitol for women who don't have PCOS? Yeah, I have taken different forms of inositol, which is the precursor, and it helps with sugar regulation. So it's not going to hurt. We definitely eat a lot more sugar than what we should. I am as guilty as could be, um, and it will help with sugar regulation, because the reality is that having high levels of insulin in your blood is like the worst thing for your ovaries. Actually, it's the worst thing for your body. High level of inflammation and a whole bunch of cascades, insulin-like factors that interfere with not only the ovaries, thyroid, adrenal, joint pain, a whole bunch of stuff. Um, Embryo transfer versus frozen embryo transfer. Again, this is very individual. Rule of thumb: if you had an amazing retrieval with a lot of eggs, you're not a good candidate for a fresh embryo transfer. If you have any precursor inflammatory conditions like endometriosis, I would not encourage a fresh embryo transfer. Um, and and then the stars need to align, like your lining needs to be right at time of retrieval. Your progesterone level needs to be less than 1.5, because excess progesterone will affect not only the timing, okay, of the lining with the embryo, but also the environment. Okay. So, you could prepare to do a fresh, understanding that it might not be the right thing at time of retrieval. And if ahead of time, you have a whole bunch of follicles, then one, just pure inflammation, it's a no, and you're at higher risk for hyper ovarian stimulation syndrome, which is worsened by a possible pregnancy. I'm doing a dual still retrieval tomorrow. I sting for 17 days. Yes, I've seen those. It doesn't happen that often, but it can happen. Good luck with that. Do the embryos have to make it to day 5 for testing? Yes, they need to make it to day 5 to be able to be tested. Now, I understand that testing is the best thing that we have. However, a normal tested embryo does not guarantee a pregnancy, okay? And even abnormal, because you have the high mosaics that could end up having normal babies. So, you know, I have mixed feelings about the whole genetic testing on the embryos. My AMH is pretty good. I just had a failed dual stim. I had a regular retrieval. You had 20 follicles with 18 eggs, 11 were mature. That's pretty good. For the dual stim in May, I had 10 follicles, 3 eggs, only 1 mature. Okay. So sometimes with the dual stim, it doesn't work for everybody. It depends on your age as well. It tends to work better on younger women. When older women do it, it's almost like one of the two is going to do well, either the first stim and retrieval or the second. That's kind of what I've seen. So one thing that you could do if you're trying to bank embryos is do an IVF cycle, and then kind of wait it out, and then do it again in a month from that cycle. Just have a period in between, kind of allow your body to recoup a little, and then you might end up having better results that way. How do we test for ovarian reserve? Mostly blood work. We can do a day 3 FSH or day 3 baseline FSH, LH, estradiol, with an AMH, anti-Mullerian hormone, and the antral follicle count. So an ultrasound at baseline to see how many little follicles are forming. What would be a reason for a normal embryo that would not attach? Well, as you know, IVF is the best technology we have so far, and it's been around for about 50 years, and we have not improved that much in the last few years because there's so many factors involved in human reproduction. For those of you who have heard me, there's some science, but there's a lot of God. So why? Because that's just the way it is. I mean, with IVF, the chances of success is 50%. That's it. It's 50%. And a normal embryo does not guarantee a pregnancy. It could be a thing of timing. It could be that the embryo didn't land in the best spot possible. There could be disharmony, okay, between the lining and the embryo. Sometimes we try to do an ERA, endometrial receptivity assay, to try to figure that out. There could be inflammation in the lining. It could be a genetically normal embryo that during the biopsy process got a little damaged. Because think about it, you're doing a biopsy on a very, very small organism. Okay, so there's even some debate about whether the biopsy itself hurts the embryo. So there's so many factors that could be involved as why a normal embryo or even a high grade beautiful blast that has not been tested doesn't attach. This is not a sprint race. It's a marathon race with obstacles. It's almost like a triathlon, and it's very, even though everybody wants to get pregnant on that first transfer, even on the second transfer, what I've seen in my experience is that that's not what happens most of the time. It takes a little bit of going up and down and left and right, and there's like some, bumps on the road until you get to the finish line. Okay. What are your thoughts on having 9 to 10 millimeters follicles at baseline? I have been priming with Omnitrope for 2 months, and I'm steaming with it. You probably are having a little bit of ovarian reserve issues, and you are recruiting your follicles on your luteal phase. I see that a lot with women with AMHs of less than 1 and close to 40 or 40 plus. There are several ways of going around that. You can, do a early or a luteal phase start, right, where your body is trying to recruit. You can do estrogen priming, so put you on estrogen and progesterone, or we can get you to ovulate a few times with like something like letrozole to have a more normal beginning and end process. What happens is, as we start aging and our bodies start, not working as well, we don't have a clean beginning and a clean end. And that's where you see those FSHs high at the beginning, estrogen high. That means that there's some recruitment that would happen at the wrong time. And then on the luteal phase, the production of progesterone and estrogen is not high enough to suppress the pituitary and the hypothalamus from stimulating those ovaries. So again, I mean, there are several ways of skinning the cat. Either we do a little bit of suppression without overkilling it, or we try to get you to ovulate. Okay, we can even do some priming with some of those supplements that I mentioned. Even the PRP might help those ovaries work better. But I really like to see the best baseline is to have those follicles small, 3, 4, 5, 6 millimeters. Hi, everyone. Hi, Brittany. I know I've been gone for a long time. Okay. Sending good vibes, everyone. What is the best way and quickest way to lower inflammation? Diet. I know you've heard Dr. Kills talk about keto and carnivore keto. And I understand that could be really hard for a lot of us. I can't do carnivore keto, but we really want to be closer to him. So on one extreme, you have Dr. Kills, who's 100% carnivore. And then on the other extreme, you have the carboholics. Okay. That extreme is bad. It's bad for anything and everything. We really want to move closer to a low carb diet. And for the endocrine system, the grains are not exactly the greatest. So wheat, corn, soy, oats, rice should be out of your diet. Okay. Starting IVF next month, and I'm having a hysteroscopy, a retrieval to remove follicle. Yes, that is not a problem. Our uteruses are as beautiful and as different as we are. So they are in different positions. I have seen them right and left and up and down in the middle. I personally have a retrorotted uterus and I have 5 kids. So, it should not be a problem. And a experienced doctor, like all of the CNY fertility doctors are, they have more than 20 years of experience each, you have no problems navigating your anatomy. I'm 36 years old. My AMH is low. Advised to use donor eggs, and I'm ready for that. I'm going to be given some shots before the transfer is done. What are my chances of success? Very good, because once you jump into donor eggs, you eliminate a lot of factors, including the famous, the clock is ticking. Suddenly those eggs are going to be the age of the donor. If the donor's 22, 23, that's how old those eggs are. And I've seen beautiful results with donor eggs. So congratulations. Okay. Monitoring for dual stim. I've had a lead follicle. What happens to them? Okay. All right. So you started with a lead follicle of 12, and then it kind of disappeared. You probably ovulated, and then just what happens is you probably ovulated that lead follicle, and then the other ones get stimulated. We've done that. We've done that before, where if you have a lead follicle that's very, very large, it's better to just let it grow, ovulate, and then kind of start. So it's kind of a luteal phase start, really. 43, just did back-to-back retrievals, responding well. Congratulations, getting 11 mature. That's fantastic. Each time in 1 to 2 blasts, taking the next cycle off and doing either back-to-back again or do a stim, looking for better quality. Do you think back-to-back with how well I'm responding to try dual stim? AMH of 2.5. You are 43, so you have to take that into consideration. I would continue with the back-to-back because what I've seen with women after 40 doing dual stim is that, again, one of the 2 cycles is good and then the other one is not. It's almost like the body doesn't have enough time to recoup and go at it again. I've seen really good results with dual stim in women in their 30s. The lady that I was describing earlier that had that breakthrough bleeding, she is 36. And her AMH is very good. She has an AMH of 4. Her issue is truly like tubal and uterine. She has some fibroids. She's had fibroids in the past, multiple surgeries, blocked tubes. So that's kind of her issue. So she herself is banking embryos because she's not sure if she's going to try to carry or not. And for her, that back-to-back duo is working well. But at 43, I would just keep doing them. Do one, do another one, because give your body a little bit more time to recoup. Okay. How many eggs are supposed to be in each follicle? If there is a good egg, 1. Like I was saying earlier, a follicle does not guarantee an egg. What a follicle says is that the process of creating an egg started, but it could have arrested at one point where that egg either vanished or is damaged, so it's a no-go. But the follicle remains, and there's enough estrogen in that follicle from the egg that maybe started growing that it'll grow to a point that we can remove the liquid, because through a retrieval we can't see the eggs. What we see is the bubble, right? The blister, if you want to call it. And then we go in and remove the liquid and then send all of that liquid together to embryology for them to count the eggs. Okay, so if there is something in the follicle, there'll be one egg. Do you think that vaginal microbe can have an effect on IVF? And if so, should we start on a probiotic and should be done before an ERA? Absolutely. I think that not only your vaginal microbe, but your gut flora, your microbe everywhere. They do say that the microbe is responsible for even our emotions, and we have symbiotic relationships with the bugs inside of us. And if you think about it, the pelvis, everything is in there, the urinary system, the bowel, and the reproductive tract. So yes, I think that it should be addressed. I do recommend women to do probiotics on a regular basis, either by food like kefir, it's my ultimate favorite, or by pills. And then having your flora, either the gut flora or your vaginal flora altered, can tilt inflammation one way or another. So should it be done before an ERA? I guess. I mean, the ERA really looks for the effect of the progesterone in the lining, but if you have a severely inflamed lining, but you will have other symptoms, if that were the case, then the effect of progesterone will be affected. But I don't think that that necessarily will have a direct correlation. At 35 and having prior pregnancy loss, would you recommend transferring two embryos? So the two embryo transfer thing is a question that I get on a regular basis. And a twin pregnancy, a natural twin pregnancy, is a high-risk pregnancy. It's a high-risk pregnancy for loss. So if you're having issues with recurrent pregnancy loss, I would really, really consider doing one at a time. If you had two failed transfers, then okay, do two, but if you get pregnant with twins, you are at a higher risk of losing them. Okay. If we start a probiotic 2 months before an FET, should that be enough time? It should. It should be enough time. I usually recommend any form of preparation and priming to be 1 to 3 months. 2 months is a good number for any type of prepping that you do. Started my IUI cycle. On cycle day 3, I have a cyst on my right ovary with open tubes. Well, the problem with having cysts in the ovaries and going through any form of stimulation is that ovary is not going to work as well. And the bigger the cyst, the less functioning that ovary will be. So it really will depend on how well your other ovary is responding. Because if both of your tubes are open and the other side is creating good sized follicles that could be triggered and produce an egg, then you should not have any issues. So, all right, everyone, time's up. It's always a pleasure to join you. I will be back on Wednesdays. I'm going to be doing one Spanish Wednesday, one English. So next week will be Spanish, but I'll see you guys in 2 weeks. May you all be blessed. Okay, bye-bye.